Hello.
Well, welcome. I've forgotten the number that this is of the Town of Windsor Human Relations Commission's conversations on race. This is Black History Month still. We're still in there by one day. So I thought it apparent to introduce what the theme was health disparities in communities of color. Before I get started and I introduce our panel, I just want to thank our partners in this, which are Grace Church, First Church of Windsor, Archie Memorial, the Windsor Historical Society, and of course the Town of Windsor, who supports our work as well. So, and I also want to introduce our commissioners. I am Judge Kevin Washington. I serve as the chair. We have Castella Copeland, who is our newest vice chair. Welcome aboard. Ms. Commissioner Armstrong, is she on? And there she is, she's waving. And that dude sitting next to her was a part of the Human Relations Commission, but he's our ad hoc member. So that's her husband, Richard Armstrong. I just wanted to introduce you, Richard. And then Patricia Mack, who is also a commissioner. I got to put the glasses on, tried to be cute. Leonard Swade, Joshua Morrow, Commissioner Rebecca Jacobson, Commissioner Linda Massa, and Commissioner Byron Bob. So those are the commissioners for the Town of Windsor Human Relations Commission, and we send you greetings. Thank you for joining us this evening. This is going to be an awesome conversation. We have four awesome, wonderful physicians, providers of service, and to each one of you, I just like to extend my thanks for the work that you do every day, because I know it's a bear out there. And I have heard many of the horror stories. So thank you for your perseverance. Thank you for your time. Thank you for your effort. And thank you for being the heroes that you are. Because without us, we couldn't be sitting here either. So without you, we couldn't be sitting here. So without further ado, I'd like to introduce our doctors to you. And I'm going to do it in the order that you guys are on my screen. So first, and the doctors will tell you a little bit about themselves, their practices, and then we'll get started into the conversation. So the first doctor I see is Dr. Terranova, Jody Terranova. Many of you know that she also serves as our town councilor. She in the past was our deputy mayor, but now she's our counselor. And the deputy mayor is right under her. I see you, Lisa. So, Dr. Terranova, would you please speak about yourself, please?
Sure. Thank you, Judge Washington. I'm excited to be part of tonight's conversation. So I am a pediatrician. I practice in Hartford at Bergdorf Clinic, where I'm the medical director. I work actually for UConn Health as an assistant professor of pediatrics. With Dr. Alerte, one of my colleagues who's on tonight on the panel. Part of my work has to do with education for medical students and residents. So after students finish medical school, they spend a few years in residency training in their specialty. And so I work with pediatric and family medicine residents in our clinic, but I also spent a few years working with all of the residency programs at UConn Health and did a lot of work with regards to diversity that I'd like to share tonight as we talk about this conversation. And then, as you mentioned, I'm also on the town council. So yeah, that's me.
Thank you, Dr. Terranova. And to your immediate right on my screen is Dr. Alerte. Thank you, Dr. Alerte, for being here. And I'll allow you to introduce yourself and tell us about your practice.
Oh, thank you. Thank you very much for inviting me to participate in this activity. I'm looking forward to it. So I'm Anton Alerte. I too am a practicing pediatrician at the Bergdorf Health Center. That's my boss right there. I think to my right, depending on where the tiles are arranged on your screens. I am a professor of pediatrics. And much like Dr. Terranova, I am intimately involved in not just the care of patients in the north end of Hartford, but in education of generations of future physicians. I am a director of the doctoring course at the health center, which is pretty much teaches students bedside manner, but also history taking, physical exam, and communication skills to and patient teaching and patient advocacy skills. I also run their clinical longitudinal in the community, so students actually spend a day a week out in primary care practices, kind of plying their trade and learning their skills that they kind of will be carrying on in their careers. And I kind of see them from the beginning to the end. Dr. Terranova and I are both on the admissions committee. So we have a hand in selecting candidates for medical school and kind of seeing them through the process into residency.
Thank you, Dr. Alerte. Appreciate you. And next is my good old buddy, old pal, old friend, Dr. State Senator Saud Anwar. Let's hear about your practice and what you bring to the conversation.
So thank you so much. I'm again honored to be here, and then thank you, Judge Washington, for having me, and I'm honored to be with my co-panelists. I'm a lung doctor, an intensive care unit doctor, so I take care of people with respiratory problems, and if God forbid unwell enough to be in the ICU, I help manage them. I'm still working full-time. I'm also involved in teaching medical students and residents in a family practice residency program. And I'm also currently serving as a state senator for the 3rd Senate District, including the towns of East Hartford, South Windsor, Ellington, and East Windsor. And also currently honored to be involved in a number of committees. I'm currently serving as the chair of Children's Committee and also acting chair of Public Health Committee, vice chair of Insurance and Real Estate Committee, and vice chair of Housing Committee, and also on the Plan Development, Judiciary, and also Appropriations Committee. So I'm honored to be here and looking forward to listening to everyone. Thank you.
Thank you, Dr. Anwar. I don't know how you got your head on tight this evening because I'm spinning over here and I'm doing nothing compared to you. We do have a 4th physician that may join us. She is currently in the United Kingdom, so it is like 10 o'clock there. So she may pop in. At that time, I'll pause and introduce you all to her. I do want to say a special hello to our state, one of our state representatives, the Honorable Jane Garibay. How are you doing, Ms. Garibay? Good to see you. And I will ask that if you could mute your phones or mute your cameras, that would be great. The panelists, you can stay live if you like. I'm going to turn it over to our facilitator, who again is my vice chair, Ms. Castella Copeland. Take it away, Cass.
Awesome. Thank you so much. So in order for us to have like a common ground of knowledge, I'm going to play 2 small film snippets so that we can kind of get a better understanding of healthcare in our country and kind of the different perspectives. So I'm going to share my screen and then just give me a thumbs up if you can see it. I'm going to do a little longer one first. There we go. All right. Just give me a thumbs up if you can see it before I press play. So that way, okay, perfect.
And so you've had some experiences as a patient where you weren't understanding English at that time. Can you tell us a little bit about that?
Yes. So unfortunately, when I was 4 years old, I got run over by a car. And at that time, I didn't speak any English. I just spoke Spanish. And so I spent 3 months in the hospital. And in my culture, you're supposed to tolerate pain. You don't ask questions. You give authority to the people that are caring for you, so the nurses, the doctors. You just don't question. So one of my experiences is as the nurses were doing their interventions to heal me, I was under a lot of pain, and I didn't know how to ask for. I didn't even know I had the choice to ask for pain medication. My parents weren't always there because they had 3 other kids that they had to care for. And it's not like we were making a lot of money. So they couldn't always be with me. So anyways, that memory has stayed very vividly with you, it sounds like. And it's one of the reasons why I got into healthcare. One of the things, because I didn't find a connection with the nurses, I didn't understand what they were doing, or the physician. I didn't get it. All I knew, I was under a lot of pain. I knew there was an accident. They kept telling me what a miracle it was for me to be still alive. But that whole process, I still felt alone. So one of the things now that I'm in healthcare, and my purpose of being in healthcare is I don't want no one to experience that, regardless of their culture, the language they speak. Connecting with your patients in the most simple ways. It can be a touch. It can be eye focus. It can just, you don't really have to say much. And if you are interpreting with, have an interpreter line and really be honest and don't mask anything, because the people can, like me, even though I was a child and didn't understand English, but I can read people's energy. You can tell when someone's being dishonest. They have a certain look to them, and it's just just always be honest with your patients at all times. And even if you don't have the answers, say that it's a great question. I don't have the answer. I have to look into that.
All right, so that is one perspective and experience. And we're going to now look to another one. This is a Think Cultural Health case study, and we're going to check it out.
There. I'm Dr. Callan. I'm filling in for Dr. Smith. Looks like you had a very successful surgery last night. How's your recovery?
Well, thank you.
I'd like to begin by doing a quick examination of the location of your surgical wound, just to make sure you're healing correctly and everything looks healthy. Can I ask you to remove your
No, I cannot remove my hijab.
Indira? I want to make sure that you're healing from the surgery correctly, and in order to do that, I need to take a look. Did Dr. Smith not tell you this would be part of the follow-up?
But Dr. Smith is a woman, and you are a man. And I cannot remove my hijab in the presence of a man who is not my husband. But that is why I came here, to see Dr. Smith. She can be the only one to do my examination. If Dr. Smith cannot be here today, I will have to reschedule my appointment.
All right. Why don't you wait here a moment, and I will check and see if she's on. Elizabeth, I'm glad you're here. This patient of yours is giving me a heck of a lot of trouble. I'm trying to examine the sutures from her surgery, and she won't remove her hijab. How am I supposed to do a post-op checkup with her?
Nadira, I'm sorry.
Ooh.
Well, I understand, Michael. It's part of her cultural and religious beliefs that a woman may only remove her hijab in front of her husband. But even if we don't fully understand it, we need to respect those beliefs when treating patients. Well, I better go check on this. I'm sorry. What room is she in?
3B?
Thanks. If you want to catch up later and talk more about this, we can do so.
That'd be great. I'll catch you at lunch. Bye.
All right, so those are two film snippets. So just to give you an understanding of different perspectives. Now I'm just going to briefly go over a couple of guidelines. I'm not sure, as you can kind of tell, sometimes when talking about health disparities and different forms of oppression and socialization, it can get heavy at times. So we have some guidelines to help us throughout our conversation together. The first one is speak from the I, so speak from your own experience. Listen to understand one another. We all have such diverse identities and beliefs. So we really want to lean in and listen, not just to have a great response, but to really understand where are each of us coming from. And that gets into our next point, into leaning into discomfort and feelings, because we are all just beautifully diverse. Like some of us might feel discomfort or not, and that's okay. I challenge everyone to lean into that discomfort so we can learn more from each other. The next one is confidentiality. So all of the stories that are shared here is going to stay here in the space, but the lessons that we learn are going to leave and go out into the community, so that way we can continue to educate those around us. Being respectful. So online, I know it's a little different. Being respectful online is making sure that we're muted while others are talking, taking turns while talking. You can also type in the chat. It's like a little bubble. So if you have questions you want to pose to the group space, or if you have a follow-up, or if you would like to personally share, I encourage you to type it in the chat, or wait until we have our audience question and answer time. And then finally, we have participate and converse. Again, this is an event for everybody, so I encourage you to challenge yourself. This is a challenge by choice. You don't have to participate, but the more you participate in our conversation, the more you'll be able to get out of it. And finally, agree to disagree with grace, meaning we all have different beliefs, and that's okay. Like we might disagree on things, but we can still maintain respect for each other and from where we are coming from. Do these sound good for everybody? Just kind of a little ground rules. Excellent. All right, here's our agenda, super brief. I'm just going to go over again to make sure we all have a common ground of knowledge. Some of us are, I know I'm going for my doctorate in education, so I might have a different background than like some of our panelists, or from like Judge, where you have a great background in law. So like we all are coming from different places, so that's why we're going to do a little purpose and context, so we all have a little the same kind of knowledge base for this event. Then we're going to get into some starter questions. Then we'll open it up to you all here in the audience. And then we're just going to have some closing thoughts, feelings for the next event. So the purpose of this event is to converse with one another on main ideas about health disparities in the Black, Indigenous, people of color, also known as Bipoc community, and to reflect on what type of change can happen. So you're going to see I have a couple of different pictures here and that share statistical information and data. If you'd like, I will be sending this out later on. You can click on each of these pictures, because I know I'm a little nerd. I like to like read the research and the articles and all sorts of stuff. So these are clickable things if you want to check them out later on. So just to define a health disparity, so we all know it's when a disproportionate number of health conditions and deaths compared with the general population. So that's where you kind of see, it's almost like when you see like a skew in the data, being like, oh, this is, there's a disparity on the lower end as it's rising up. So here's again, some brief, very brief salient points. This is not all inclusive with all the knowledge out there. There's just so much out there on health and health disparities and all these different things. This is just very brief. So historically, the Black, Indigenous, people of color community is often underserved. There's a deep history within the United States of America on that. And there have been many programs to help reduce the disparities through education and trainings. There's also newer socioeconomic opportunities over the years that have changed with the development and advancement of technology and health awareness and education from young ages. So the CDC has a great knowledge base, and there are also other organizations as well, nonprofit. Some of them are federal and state as well. So you're going to see a couple of those throughout the presentation. But again, this is just an infographic about specifically the African-American population, from high blood pressure to diabetes to strokes. And this is from 2015. So again, trying to find the most relevant data, but we are constantly living through, like, you know, a lot of different disparities even to this day. There are many causes of health issues. I'm not a health expert. I'm just going to say that right now. But there are many different factors that go into health, including social and cultural factors. Again, this is just a brief kind of layout of health outcomes, factors, and policies and programs and how they are intertwined. And again, it's not exhaustive, but it kind of paints the picture that there are a bunch of factors that go into the issue of health disparities. So it's not just like one thing. There's just many things that are coming together. I like to see it as a bunch of small roots coming up and they make one big tree. There are all these different roots that kind of come together. Finally, we have accessibility to healthcare, specifically in our country, in the United States. why is it links to the job we have? You know, there's like a rich history between like health and class and health and race and who has access and who doesn't, and who's worthy enough. So if you would like to, you can check out more information on what's called the intersectionality between these concepts. And there's a breakdown based on the racial data that we have. This is updated on the US Census Bureau. So if you want, you can check out their website. They have more updated data based on the 2020 census. And finally, there are a lot of health disparities that are driven by social and economic inequalities, because again, there's an intersection between these different, not only identities, but these different disparities. So this is just a brief infographic. If you'd like, I can send you the link as well to check out how education plays into the healthcare system and how the neighborhood and physical environment play into community safety and social context. So all of these things, again, are interconnected, and we're going to be kind of unpacking and asking our panelists some key questions about, like, well, what can we do about it? This is such a large issue. Like, what are some of these action steps that we can take? So I know it's just a lot of information, just very, very brief, because again, just so we all have a kind of common ground in our understanding. But now I'm going to turn it over to our panelists. We're just going to kind of go down some of these questions. I will also put these questions in the chat, because I'm a person that has to kind of like read it a couple times and then like get it in my head and then answer it. So I'm going to put it in the chat as well. But we're going to start off with, what is one of the largest health concerns for Black, Indigenous people of color in the time of COVID? And how has the pandemic exacerbated or kind of stretched out the accessibility to resources? So I'll give everyone a minute to kind of read it. I'll stop my screen share, and then I'll popcorn around to our panelists. All right. Gonna stop my screen share. There we go. And I'm going to hop on over to Dr. Alerte. Would you like to answer it first?
Oh, I should have seen that one coming alphabetically, and yet I find myself looking for words to say. Okay, so in my opinion, I think the biggest health concern before COVID, and especially exacerbated during COVID, is the glaring lack of behavioral and mental health appreciation of the problem, both within the patient, within the community, and as well as appreciation of the problem from the folks outside the community who are tasked with making it better. I think the notion of, it's almost English, you know, keep a stiff upper lip, right? And Black don't crack, are kind of the same notions just across the pond from each other. And I think that there is a underappreciation about how severe these problems are. They are problems kind of brought upon by family history, medical history, but probably just from the environment that you have to wake up to and go to sleep to day in and day out. As a kind of very brief tangent aside, is I'm very interested in disabilities in pediatrics. I'm very interested in school success in pediatrics. And I find myself day after day trying to figure out, well, is this really ADHD? Are they really hyper, right? Do they really have a language problem and a learning problem? Or are they anxious, depressed, or just plain sick and tired of being sick and tired? And I find that challenge a continual kind of challenge and a continual kind of investigation that I need to take place when addressing my patients and their families, not just to diagnose things, but to kind of also understand, okay, what's going to make it better? What's definitely making it worse? And how can I kind of maybe help to kind of ameliorate all those things that are, quote, making it worse? All right, and I'll stop right there.
Mm-hmm. Oh, absolutely. Thanks so much for sharing, Dr. Alerte. And I see in the chat, Jay shared that It might not necessarily be kind of germane to the discussion, which it is, because again, there's that intersection. But there's a huge issue with health disparities for persons with disabilities. So just keeping all of these different perspectives in mind. So thank you for sharing, Dr. Alerte and Jay. I'm going to move on over to Dr. Anwar. It's your turn to answer our first question.
Sure. Thank you so much for the question. And I agree with Dr. Alerte. I would just say that, again, I wear two hats. From my policy hat, to me, the pandemic has highlighted what many of us have been screaming about for the past many years, that we have a broken system. And to me, the biggest issue is that unless we fix this system that is resulting in multiple illnesses that are disproportionately impacting certain communities, we will not be able to address this. So we need really to first acknowledge that we are part of the problem at all levels. And then we actually, after that acknowledgement, put our hands together and try to fix it. And I can speak in a little bit more depth, maybe in the Q&A opportunity, of what I mean by systemic reasons of why we are here. In one simplistic term, in the sentence, which is that the community members in the minority communities do not have equal opportunity of a healthy life. And when you don't have an equal opportunity of healthy life, then everything else just follows as a domino effect of the lack of access and the lack of training and empathy towards recognition of where a person is coming from and how to address those things. So to me, that is a central issue, and this pandemic has highlighted this, and this is the time for us to address this. Otherwise, we will continue these conversations forever. I'll stop here. Thank you.
Awesome. Thank you so much. It's very comprehensive so far. I know, like, y'all are incredible doctors, just not only with your knowledge base, but for what you're doing in the community. And that definitely shows. So thank you. Dr. Terranova, go ahead.
Thank you. So one thing I'll talk about is how directly COVID has impacted the communities of color, because we are already touching upon these inequalities in health related to structural problems and inequalities in access to healthcare. And so we have seen through the course of the pandemic that communities of color are getting the most sick and losing the most people. And there is not a day that goes by that I do not see a patient that hasn't lost a family member or friend from the pandemic. And that is happening every single day when I talk to patients. And so we can just see the severe impact that COVID is having directly on our patients.
Absolutely. Thanks so much for sharing. So I know that we're kind of going in a lot of different ways with the conversation, which is great. And this kind of gets into our next question. So continuing on the theme of health disparities within the BIPOC community, in your own words, how are Black, Indigenous people of color treated within the medical profession? I know it kind of varies from location to country to all sorts of factors, but what are some of the social or cultural implications that contribute to how people are treated? In the videos, that's why we had those two film snippets, which thank you, Judge Washington, for providing those. There are different factors that kind of come into play, whether it's race, whether it's religion or sexual orientation. So there's all these different factors, but how does that contribute to how people are treated? So I know it's a big question. Again, I'll put it in the chat so you can read it, think about it, digest it, and then we're going to chat about it. And then we're going to go to Dr. Anwar first. You see, I'm just going to popcorn around. Whenever you are ready, you can share out.
Short answer is not well. And the longer answer is that it starts from day one. When we actually are in medical schools and education, we actually do not recognize the historical perspective, looking at the individual's background with experiences. And at times, I'd like to be somewhat blunt, we create judgmental healthcare professionals who right off the bat on the entry of an individual will start to judge them, and in their minds start to think that the person is unwell because of their own personal choice. And we do not look at the social determinants of health and how complex and important they are, and the personal experiences and generational experiences of the community. So without the generational experiences and the trauma and the impact that individual has had, we are trying to build on our understanding of the illness-based model rather than a community-based understanding of the community. And sometimes the society has set up a mechanism now that you have to interact with individuals in 15 minutes because the insurance industry controls more and more of how fast we are churning the number of patients around so that our employers will make more money and their CEOs will make more money, and us as the quote unquote glorified blue collar worker doctors are churning more and more patients into that time frame. So we are not even able to touch the human inside of that patient. We're not able to understand their experiences. And all of those things have created barriers in recognition, respect, trust within the community, and also recognizing that the healthcare industry has not been kind to the minority community in an organized way. If you look at the studies and how they have been performing, even until recently, if you will, we have done some really things that we should collectively be very sad and sorry about, including a few years ago, they did a study in Africa where they were using placebos for HIV medicines when HIV standard of care was available. And this was CDC, NIH supported studies years ago. And this is where we are, and there is a problem. And unless we recognize that and stand up and fight for this, we will not have that trust. I could forever, I'm sorry, but I'm just gonna stop here.
No, absolutely. Thanks so much for sharing. Yeah, as you were talking, it's kind of like seeing how capitalism ties into all of this, how people are more important than things, including profit. But yet we know that that's true, and yet we continue to perpetuate the system, which is just, like, so I'm right there with you, Dr. Anwar. But thank you so much for sharing. We're going to move over to Dr. Terranova for our second question.
So yes, we have a lot of work to do to still treat people equally, and we are trying to do that in the medical education world. And I want to talk a little bit about kind of the importance of bringing in more people of color into the profession, because that is part of how we can help correct this problem. Because me as a white physician, I need to learn from colleagues of color how to take care of patients of color, because that is not how I grew up and that is not the place that I'm coming from. And so we need to learn from each other and learn about each other's cultures. And so having more diverse people in medicine will really help us do that. And so we take a conscious effort, at least, at UConn, to try and bring in more students from underrepresented backgrounds. And we also have built this community of reporting when we see mistreatment of patients, mistreatment of colleagues, so that people feel comfortable speaking up and so that something can be responded to and acted upon. And on the flip side of the video you showed about the Muslim woman who did not want that physician to take care of her and to be able to understand, to respect that as the physician, we've also done some work about not allowing patients to be discriminatory. So if it was the other way around and there was a white man who did not want a Muslim woman taking care of him, that she was the physician, and he was really essentially just being racist or discriminatory, finding a way to say that that's not acceptable, that you cannot be discriminatory against a provider. You can't say, I don't want a Black physician, I don't want this person, I don't want that one, and to make sure that people feel comfortable standing up and speaking out and saying that is not how patients can treat providers either, because it does, I think, discourage people from going into healthcare sometimes when they are not respected. And so there's actually been a lot of work that I was involved with at UConn to create a policy about patient rights and responsibilities. And so patients can have the right to request a different provider if it falls under their religious belief, or if it's a woman who had been sexually assaulted and doesn't want a male physician. But beyond that, patients really can't refuse a provider based on essentially a protected class. And so that's something that's newer. It was maybe 3 or 4 years ago that we started working on that. And I think we need to see more and more of that happening so that on both sides, the provider side and the patient side, there's mutual respect and understanding.
Absolutely. Thanks so much for sharing. So it's kind of seeing how it's like a two-way street. It's not just all on the doctors. I can see similarities too in education where it's like it's not always on just like the person who's giving you the service. It's got to be a bit like with the patients or the students as well. So thank you so much for sharing. And finally, Dr. Alerte, for our second question, you are up.
Okay, I think I've been working on this response for about 4 years because I've been thinking about this. The strengths and the weaknesses of medical school or any professional school is thus. As a medical student, you have to memorize thousands upon thousands of facts. The femur is the long bone, the retina does this, the heart has 4 chambers, and you memorize facts and you memorize fact after fact after fact after fact, and you're tested over and over and over again on all of the minutia, which ends up being super important. But you learn them as facts, right? The femur is the long bone, this nerve innervates this heart does this, at this pressure, Black women have, and then you learn Black women have a higher mortality rate than white women. And then you learn that Black people have a higher pain tolerance than their white colleagues and white counterparts. And you start to accept, and then, essential hypertension. Black people just have high blood pressure for no reason. We don't know why. And you just start to kind of, well, it's a fact. I have memorized yet another fact. And some of them are facts. The femur is the long bone in the leg. But some of the other stuff is a situation, not necessarily a fact. But we kind of put them all together as stuff that we have to memorize and spit out when asked to prove that we know what we're talking about to our teachers. And then the last nail in the coffin is exactly what Senator Anwar kind of alluded to. Actually, not even alluded to, stated. And he's accurate. We start to put virtue on things that aren't necessarily virtuous. Having a car is not a virtue. Having a job that allows you to take a day off to take your kid to the psychiatrist and then to the pulmonologist and then get a PPT and then do, and then to another specialist is not a virtue. It is your good fortune to have a job that gives you plenty of days off to take care of your family. Speaking English as your first language is not a virtue. Just works well in a predominantly English-speaking country. But we start to treat these things as virtue. We start to treat those things as the right way. And then they kind of look, well, if you can't make your appointments because you have no car, if you can't make the last follow-up because your job will not let you have another day of work until you work 30 more days to get that one day off, then you just don't care enough about your health. That you just aren't as invested as you should be. The mom of the child in the NICU who isn't able to be at the bedside, who everyone kind of looks down on because she's not there, probably has a really good reason, if not many good reasons, why she cannot be by her child. But we put that value judgment on it, and then we are done. We are morally compromised. And that is a problem that we need to really face and look at. The system, how we grow up, whether we can kind of leave our cars unlocked, or I left my garage door open last night completely by mistake because my kid was looking for baseball equipment. I woke up and all my stuff was still there. That's not a virtue. That's luck, blind luck, and good fortune that I live in West Hartford. Okay, doesn't make me better, right? Just makes me luckier. But we kind of mix those two terms, and that's where we get into problems across many things, but especially in medicine.
Absolutely. Thanks so much for sharing. I kind of, when you were talking, it really reminded me of how we socialize ourselves into bias, and how it's just like baked into our society now. And it's just like, but how can we now have the critical thinking skills and analysis skills to determine what is fact or what is fiction? Like you were saying, it's like, how can we, like, this is a fact, this is a situation, and there's like a distinct line between the two. But how do we re-educate each other to now have that tool and be like, okay, I can see the difference? So just again, thank you so much for sharing. It's a very, very complex issue. And speaking of complex issues, we're going to take a brief pause. So if anyone in the audience, you can type your question. If you have any follow-ups or things that you would like to share, we're going to take the next 5-10 minutes or so to do that. And you can ask our panelists any questions before we move on to the next set. Go ahead, Marcia.
I just, this is just personal, I guess, but I went from being a public school teacher, which I loved, to being a school social worker in Hartford. And what I decided was, and I'm hearing this with the medical profession too, all educators should go to social work school. Because I mean, my point is to support everything that you're saying, because we look at the child in front of us in a classroom and think that that's the whole child, and it's not. And the one time I was working with a kid who had been kicked out of school, one of my favorite kids, but he'd made a fairly serious error. But he was late for my tutoring one time, and I said, you're late. And he said, Miss, don't you know I have a grandmother to take care of? And it was such an eye-opener, because they have lives that we don't consider. So it's a relief to me to hear you talking about this. It's how we make it happen so that the training is across different professions. I just had to share. You're touching my heart is the issue.
Thank you so much for sharing. Yeah, it's a lot of it is about that perception, because we can't see. It's kind of like that iceberg. You can't see what's underneath. You just see the tip of it, and there's just so much more, so much more. So thank you for sharing. Any other questions? You can type in the chat or raise your hand. Do you have an actual hand, or if there's a digital hand? Either's fine. Go ahead, Judge.
Yeah, I just wanted to say also from a personal perspective, it is not always tied up in the fact that it was recommended to me that I find a physician that looked like me, that probably would understand my issues and stuff like that. And I didn't find that to be so. I didn't find the fact that I was Black and he was Black to be and to me. I felt like more disrespected from seeing a person that looks like me than I do with the doctor that I have now, who happens to be Middle Eastern. And he's more caring and more in tune to what my needs are than the African-American doctor that I saw. So it's not always tied up in the fact that, we need to go see physicians that look like us. It's almost like the bedside manner was just totally different between the two. And I don't know if that speaks to Dr. Terranova's point about, if there is some cultural training that needs to be done within med schools. Everybody doesn't bruise the same. If I read in a medical book that, the bruise is supposed to turn blue, or underneath the skin, you'll see that the skin turns this color because that's a blastoma or something like that. My skin doesn't turn blue when I get a blister. So, what define that for me? My skin is not white. So I just wanted to state that.
Absolutely. It's kind of like representation matters, but to what extent and how is that information conveyed, whether it's within textbooks or education and how we treat one another. So thanks so much for sharing. Any other questions, thoughts that we want to share before we get into our next group of questions?
To the
Yeah, go
judge's
ahead.
point, if I can jump in, I couldn't agree more. There is a false sense of success by saying, okay, we're gonna, I can't, like we need to have, more Black doctors, and that is true, and it's always like to treat Black patients, but I'm like, well, not necessarily. And I've had more white students come to me saying, Dr. Alerte, I don't know if I could do what you do at the Bergdorf because, well, and I'm like, what? Well, I'm not you. I'm like, well, you're not an old Black man? Sure, you're not. But what? He's like, well, I'm not there. And I'm like, stop right there. Do not delegitimize yourself. I've had more honest, caring, thoughtful, activists, white students say, I can't do this because I'm not real. I'm not keeping it real. I'm not part of that tribe. I wouldn't understand. And I'm like, look, I was taking care of kids before I was a parent, before I actually knew what staying up all night really was, right? What I knew being scared for a child really was. I was taking care of women, pregnant women. Never gonna be pregnant myself. Do not remove your legitimacy, because people will say that. It's like, who are you to say this? Why are you standing up for Black people? You're Irish. And I'm like, not true. They're human. And they're sticking up for another human. And I think that's probably the most important, thing that kind of needs to get conveyed. When we talk about education and bedside manner, they're human. Start treating them as such, and then work from there.
Mm-hmm. Absolutely. Thanks so much for sharing. Yeah, it's more about listening empathetically to build that community. So it's not just like about you or that personal identity, but how we can better support one another. So absolutely. Thanks so much for sharing. Any other questions, comments, things that people want to add?
Another comment I just want to mention is, in the past, a lot of doctors used to visit patients' homes. And you would have such a fascinating understanding of a patient when you are actually in their home and interacting with them, and you look at the environment, how that is impacting that person and their realities. And then now it's like we are seeing them in our offices every 15 minutes. So we are not seeing that human. And that's the detriment of the corporatization of medicine in the last many years, which is restricting us to be able to be good humans and good professionals. I still try to see some of the patients more so because of the fact that they have a lung disease, which would make it very, very difficult for them to come to see me. It's easier for me to go and see them because of their illness. But I try to go and see them in their homes, and I get so much more insight into them and everything that they've experienced, and have more conversations. And that's the part. Nobody goes into medical school to see people in 15-20 minutes and bill and add that. And some of these things have taken the spirit out of this whole industry at this point. And that's part of our challenge that we have to address as well at some point.
Mm-hmm. Absolutely. Thanks so much for sharing. I can kind of see parallels too in education, because I'm an educator. So it's like, it's a lot of parallels with what you were saying. That's just like, oh yeah, same here. Great. That's it, but thank you so much for sharing, Dr. Anwar. And I see Marsha shared in the chat, I'm learning about other cultures. So trying to really meet people where they're at instead of changing who they are, and really taking that ownership to be like, I'm going to learn about more of the Muslim community, or more about the Jewish community, or more about different identities, so that way we can form better relationships and connect with each other. Go ahead, Meredith. Oh, you gotta mute yourself so we can hear you.
Hi, my name is Meredith Johnson, and I'm a CPS supervisor. So I am really, my focus is child protection. And I find that the truth as it relates to I'm not so much a strong proponent from Western medicine and maintenance based on many providers believing that, or I'll say consumers believing that they don't have a choice related to their their rights as it relates to medical intervention. And I feel that oftentimes in the more disenfranchised communities, they often don't feel like they have a voice with medical providers. And as it relates to COVID, in some of the urban communities where we know some of the conditions exacerbate breathing conditions and things of that nature, I've seen situations where children have been brought out of the urban community setting, transition to maybe a more suburban setting where they have more access to open space. Maybe the allergens that are in the urban tenement setting is not present. And then there's a force, oh, this child still needs that asthma medication because that was what was prescribed to them. That was prescribed because they were in an urban setting where it was exacerbated. They're in a different setting. Those symptomologies may not be present. So don't continue to give maintenance medication for symptomologies that's not currently present. But parents don't necessarily have the language to communicate that. And so now we have a situation where you have a child who no longer needs steroidal maintenance, but is continuing to be forced for it to be administered because of this dynamic. And us as systems, CPS will, say to, in this situation, it was a foster care, you're being neglectful because you're not giving the medication that the child was prescribed when the child was in a different setting. And you're just like, wow, don't you understand that the conditions that exacerbated the breathing is no longer present? So again, the lack of education about certain things is really detrimental. And so as it relates to being a person of color and being able to support maybe other people of color who don't feel like they have a voice and feel intimidated that their voice is not validated, that is where I use my cultural humility to code switch and help educate them about certain things. And I'm certainly not a medical practitioner, but I have been in enough medical situations to kind of navigate some of the baseline things. But it is very tragic. And when children have been isolated because of COVID, it's a more exasperated situation. So I don't know what we're going to do with how long it's going to take us to recover from this situation.
Mm-hmm. Absolutely. Thanks so much for sharing, Meredith, especially because a lot of this is circumstantial and contextual. As we now we navigated into COVID, how are we going to get out and how are we going to heal and move forward? So definitely thanks for sharing. We're going to go to Lisa Bress, then we'll go to Liz. Go ahead, Lisa.
Hi, thank you. I just wanted to say that a theme that I'm hearing across our distinguished panelists is making assumptions. And it seems to me that what I'm hearing is that in many, many cases, people on both sides make assumptions about people instead of getting to know who they really are. And I know that Senator Anwar has described that the system as it's set up sometimes forces people to make assumptions because it's a very short period of time and people are trying to help people. And therefore they go automatically to whatever preconceived notions they have about these patients. And my question basically is there a way or how might we educate doctors and patients to think more before they make assumptions, which is probably a tall order, but I'm just curious if there's been anything that's been successful in helping people see each other more clearly before making assumptions.
How much time do we have? I'll try to start this, but I know my co-panelists and many others will probably have far more insight into this, but I'll just say that it's important to have a humility, like Meredith was saying, that having a cultural humility about individuals. And you also look at the fact that all race is a cultural, is a social construct. So if you look at medically speaking, we are all the same. But because we have different skin colors and different backgrounds, that those are all social constructs. If you start from that point that this is a social construct, and then you also pause multiple times to start have your brain think a little better. The brain works in such a way that we want simple answers, and everybody wants a simple answer. They don't want to think about things, and when you, especially if you're in a hurry, so you have to pause and try to, in your moments when you're alone, you start to say, why did I think that way? And then you question yourself, and it's a lot of internal conversation that are needed. And not being of, for example, I'm of Pakistani heritage, so I don't know the African American experience, but the only way I can learn about that experience is to immerse myself with my friends and then understand the background and try to take the all the experience that many of the people have had for generations, and then empathize with that. Try to go into and get comfortable with being uncomfortable, and then learn about the individuals. And it will require investment. And this is part of the conversation we are having, is that we have to start to step into areas which our brain is telling us, no, keep it simple, and then move forward and then make this assumption and move to the next step. And then we have to undo that. And that would require consciously doing it. I'll stop here. I'm sure others have better understanding that I can learn too.
No, absolutely. Thanks so much for sharing. It's unlearning that bias. It's definitely a process for sure. Thanks so much for sharing. Go ahead, Meredith.
I'm sorry. I guess I'm triggered. Someone spoke about the mortality rate of Black women, and as that was said, there's so much mental health symptomology that actually mirrors medical symptomology, like the panic attacks, and the feeling that I'm having a stroke, but I'll dismiss that because maybe it's just a panic attack. So you don't call 911, but you were actually having a stroke. These are the things that, education and just learning and speaking in forums like these, I think are great, but that's such a long way to go.
Absolutely, for sure. Thanks for sharing. Go ahead, Liz. I see you had your hand up.
Yes. I retired as a speech pathologist about a year ago. And one of the things I just became convinced about was vocabulary. Vocabulary can be such a barrier to understanding. And following on Dr. Anwar, the idea that we keep it simple. I think drawing a picture, explaining what a word means, showing a body part, using simplified terms. And if a person had a stroke, we use the word aphasia. Well, who in the world knows the meaning of aphasia? Or dysphagia, which is swallowing problems, who knows? And until we make those words simple, people don't understand that the esophagus and the trachea are two different things. And you have to draw pictures and you have to make it meaningful. And what I think, if we don't simplify the vocabulary, we lead to phenomenal misunderstandings and misinformation. And I really began to see that vocabulary was a very successful way to build a wall between our clients and ourselves. If we wanted to keep that appointment to 15 minutes, don't be clear. And if you want to have that human discussion, it takes more than 15 minutes because you have to be clear. But it's real easy to not do that. And I think vocabulary is huge.
Absolutely. That gets into like making sure communication is accessible. Like who are we doing this for? Is this for like the people in the big corps, or how are we actually connecting? So thank you so much for sharing this, because it's, again, very, very complex, but like how can we make this more accessible where people are at? So absolutely. Any other final thoughts or comments before we move to our next question? Don't worry, some of the next few questions are going to continue some of the themes that we've been talking about. Go ahead, Judge.
So the thing I wanted to say, I also work with Centers for Disease Control and Medicare and Medicare, CMS, and Medicare and Medicaid. And what I am perplexed about. I know Dr. Terranova and Dr. Alerte work with pediatrician, work with the kids and the babies, and also, and Dr. Anwar. I don't know, and maybe you all can answer this question. Maybe the mindset, as we are an older set of people, that we need to see a certain kind of physician. Do you find that transcends into your patients, your pediatrician patients? And do you find that, Dr. Anwar, also with your lung patients, do you find that the more mature your patient is, or in your case, Dr. Alerte and Dr. Terranova, the mindset of the parent is transcended into the child? About that cultural bias, or that ageism is coming into effect?
For me, the ageism really kind of hits when a young woman hit puberty, because that's usually when they are pretty much done seeing me as a male provider, and that's a comfort thing. It's not a race thing. And that's probably the most common reason I kind of say goodbye to patients or transition them to some of my colleagues. But there's a bunch of different reasons, or a bunch of perceived reasons why a physician may be a good fit for you, right? Some people say, well, like you're kind of a dude and I'm a girl and I have girl issues, and I don't want to talk to you, of all people, about girl issues.
Right.
But, so we all have those preferences.
I just find it interesting that I've heard through CMS and reviewing Medicare and Medicaid patients, where the older patient is thinking of the mindset, well, he only spent 10 minutes with me. How could he know what's wrong with my lungs? And I wonder if that mindset from an older parent or grandparent that's taking a child, a child caregiver, relays that into the child, that, it's like, well, little Jimmy broke his arm, but Dr. Terranova only saw him for 10 minutes and assumed that it was a cancer in the arm. So I just wonder if that ageism takes effect, why, if the patient's parents are mature, or the patient themselves, about the kind of care that they're getting.
This is go ahead.
No, I'm sorry, Senator.
Save me, Dr. Alerte.
Okay. I'm not sure it's age specific as the definer of, did this doctor do a good job with me? Or am I satisfied with my care? I think it's the time. I really think it's the time. And I tend to kind of be long with my patients. Some of my colleagues are even longer. But if I am going to take 10 minutes, in that time, I'm going to explain to you why I think this is a broken arm as opposed to a cancer. And I'm going to walk through it with you. And I'm going to use the right term so you understand what I'm thinking. Because no one likes to be blown off, right? No one likes to kind of, have the doctor just be like, yeah, not look up, ask a couple of questions, be like, okay, here's a prescription. Let me know if it gets better. Bye. Right? No one wants, it's not good in any interaction where you seem like someone's not paying attention to you, be it a restaurant, a lawyer, or your doctor. But I think the time part is the most crucial time, and it's not quantity, it's quality. Because 10 minutes, right? Like a commercial break can seem like an eternity. It's 3 minutes. If you are actually really invested in really talking with that person, those 10 minutes, although brief on the clock, you may have had all your questions and all your fears kind of laid aside. So I really do think it's the quality of time that's probably the biggest, the biggest bugaboo of patients feeling like they really, really have a good doctor.
Well, do you think that it's a matter of the system that is telling our providers that, okay, you need to see this patient in 15 minutes and then turn over to the next. So how do you all as providers take back to the system that, you know, I need to care for my patients. I want to care for my patients. And you telling me that I need to be out in and out of this room and do these notes in 10 minutes is going to be effective. We need to change this narrative. How do we as patients coming into you assist you in doing that?
I will try to address this, if you will. If there's a private equity or a corporation that owns a practice, or insurance company. Now, one of the biggest practice in the state of Connecticut is owned by an insurance company. And I put a bill every year in saying insurance companies should not be owning medical practices. There's a conflict of interest because their evaluation of us who get unwell with their health is a medical loss ratio, which means that if you get better, they lose money. So you're not getting better is financially better for them in many respects, or you're not seeking help is better for them. So they have no business owning it. And there are 29 states that don't allow it. Connecticut allows it. And I'm trying to undo that, but I'm not powerful enough for the insurance companies yet. But with all of your help, maybe we will be getting there. So, that's part of the challenge that we have. What I know is many of the physicians are actually leaving these corporations and trying to do something if they can, because you don't get the satisfaction of your profession if you're unable to perform, no matter what profession it is, no matter what. Everybody has pride in who they are. I'm thankfully self-employed, so I have the luxury to take the time and address some of that. I know my wife is a primary care. She actually left her job so that she can be able to spend the time she would want to, because she was asked every 15 minutes they have to see a patient. And she said, I can't do it because I'll miss something. And then it's living with missing somebody's illness, and then a bad outcome is worse than anything else. So she said, I will make less money, we'll be happier, and then that's what we'll do, and take it. I said, by all means, because that's what we have to do to be taking care of our patients. The other thing to your other question, Judge, is that what I have tried to do is every patient who comes in are of different age groups and are different genders. So you try to look at your family member in them. So if they are of your children's age group, you look at, this could be my child, this could be my sister, this could be my mother, this could be my grandmother. And when you try to have that perspective and you say, this is how I would want my grandmother to be treated, your focus changes much more, and then you're able to, because that's a litmus test. This is how we would want our family to be treated, and that's what you do, is you treat everybody like your family. And that's helped me get through some of the challenges in some respects. But this will require more intervention and systemic change. The other thing is we do episodic care. If I treat a pneumonia, I get paid more, but if I treat a bronchitis, I get paid less. And then frankly, if I prevent the bronchitis and prevent the smoking, I don't get paid anything. And frankly, the more we prevent, the more beneficial it is. So the healthcare system is upside down. It is illness treatment setup. It is not wellness focused. And that's part of what we have to start to focus and push for. And then financially, insurance companies will make more money that way too, but they don't get it yet.
Right. Thank you.
Mm-hmm. Absolutely. Thanks so much for sharing. I see Liz, go ahead.
In my profession, a number of my former graduate students have left the field over productivity demands, where they have to have this extremely high level of productivity, almost no downtime. And it leads to real severe ethical concerns in places such as a nursing home, where they are being encouraged to meet productivity standards to offer treatments that are absolutely unacceptable, such as working with someone with advanced dementia and an iPad. And one of my students said to the director, but this woman doesn't even know how to use the call light. They said, it doesn't matter. Of course, if you just work with her, she can learn to use an iPad. And it had nothing to do with the lady's ability. The lady was in advanced dementia. It had to do with being able to chart those minutes and be able to get those charges. And she left the field and just said, I can't do this. And that, I think, is happening a great deal. But the productivity kills people, because it's just exactly what you were saying. You don't do quality work. You're getting in your minutes.
Can I add something to Cassie?
Sure.
So I think one of the issues with not being able to spend time with patients is that you tend to standardize your care instead of individualize it. And we lose that opportunity to learn about the patient and learn about their home and learn about their access to things. And so we just say, oh, we'll just go to the drugstore and get Tylenol and do this and do that and whatever. And maybe they don't have a drugstore nearby, or families that live in Hartford don't have a grocery store nearby. And we say, oh, just go get fresh fruits and vegetables and do this and do that. And really miss the opportunity to understand and learn what the patient has access to and how we can give them advice that fits their situation. We have a lot of children with obesity now, before the pandemic, and even more so now. And we have, students that come to us and grew up in suburbs and say, well, just let your kid play outside in their yard and just, go to the park next door. And the kids in Hartford don't always have a yard or have a park next door, or their neighborhood is not safe for them to go outside. And when you only have 10 minutes with a patient, you don't have the time to learn that and understand that and provide the best care for them. So that's part of the problem with the system too.
Mm-hmm. Absolutely. Thanks so much for sharing. Monica, is that how you say it? Would you like to share next?
Monica, thank you.
Monica.
Hi, everyone. So one thing that I've been hearing a lot is like access, right? The word access has come up a lot. And so one of the things I'm a member of the state's maternal mortality review committee. And so one of the things that we see is unproportionately Black and brown women are dying from childbirth within the 1 year postpartum period. And so now one of the things that's also happening around the state is the closing of maternity units at some of the smaller local hospitals, right? So they are not having access to prenatal or, during delivery, they have to go to Hartford or another hospital, right? Because Wyndham has closed down, Day Kimball is closing down, Johnson Memorial doesn't have maternity services, right? So there's no access to the proper care. And also with that, even at places like Hartford, right, the staffing ratios are so off that sometimes when a person does come into the emergency room, they don't have access to the care that they need even at the hospital because staff is stretched so thin. So what do you believe? And I know that this is a little bit of a difficult question because they are your employers at the end of the day. What responsibility falls on physicians and also patients to demand safe staffing ratios and to demand that services continue for these populations in the community?
Can I take a stab at this? Actually, Dr. Alerte, you can go first, please.
I'm about to light something on fire. Okay, so I think there needs to be a second Emancipation Proclamation, a second one. The first one was great, loved it. I think we need a second one. I think the only thing that's changed, right, from 1865 is that we have a pay scale now to our untiring labors. And Madame Alerte didn't send her kid to school to be like Lucille Ball, shoving chocolates in his mouth as the machine goes faster and faster and faster. For those of you who remember Lucille Ball, I'm old school. I think patients need to kind of say, and I even got the slogan, I deserve more than 15 minutes of your time. I deserve more than 30 minutes of your time. I just had a baby. I deserve more than 2 days in the hospital, right? And I know, those 2 days were based on studies of, rates of complication and all those things. But when you talk about, I'm always running late. And I feel really bad because people took a day off to come see me. Like that was their day off. But I am spending time with people. And it's pissing everyone else with like a 2 o'clock appointment because there's a 3 and my 3 is a 4 and my 4 is a 5. But people deserve more time. And the insurance companies aren't going to change it because it's, like X over Y. It's a math equation to them. It's 50 patients a day times this many dollars per copay. Yay, right? That's a very positive equation. We're not going to change it on ourselves because as physicians, we just do it for the love of working, and we're just going to keep working. And we have not been empowered to we don't go on strike. We're not walking off the job. We're not going to picket. We have patients to see. And they know that. We're caring people. We will give our vacations, give our family hours to finish that note, call that patient. It's going to need to be the patients going, I'm not just going to give you 1 star. I'm giving my insurance company 1 star. Do not like, would not recommend. I need more time. And you see, that's me throwing a Molotov cocktail into the works.
Thank you. This is fascinating. And Monica, I just add a couple of thoughts. First, one way to be able to address some of these things is to talk to your legislators. And if you live in Windsor, Representative Garibay is, I have a bias. I think she's one of the best legislators I know. She is my superhero, and I've seen her in action. And it's a blessing to work with her. And then I'm there as well to do whatever I can in this situation. We are trying to fight the Wyndham situation with Heart Hospital, and we're trying to see. We just had a conversation on the CON prospect that we are looking at. The CON allows some of the facilities to withdraw some of the services. And while I have problems with the CON for coming in, but for leaving, this should actually have to go through a process. When you actually have a conversation, what has happened is that the hospitals do not have the 24/7 coverage for women's health. And that is linked to the fact that the OBGYN are leaving the state of Connecticut, which is based on the malpractice insurance and the lack of tort reform in our state, because our lawyers have such control in our state that the malpractice insurance is so high that OBGYNs are going to other states. There are about 15 states or 10 plus states that are out there. 5 are looking at changing their laws too, where there's no homestead, there is homestead protection. But in the state of Connecticut, if you are OB doctor, a child has a complication for one reason or the other, your home is gone. You don't own a home, you're on the streets, you're homeless after 16 years of education, training, and work. And we don't have those protections. So people are saying, you know what, why should I put myself at risk? So they're moving to other states. And that's why the hospitals are closing. And if it gets to that critical point that no woman can have a child in the state of Connecticut, maybe then I can get enough of my legislators to say, fix this malpractice insurance, which is killing the healthcare institution in our state. You need to have malpractice. You need to actually make sure that people who are doing wrong, they have a mechanism to be held accountable for that. But to be held accountable to the millions of dollars, which are exuberantly high, does not make any sense because it's not happening in other parts of the country. So it's sort of creating issues. The other thing that's happening with doctors is that's one of the fastest growing groups, which is actually doing suicides because of what's happened to them. They're also the group that's actually leaving our state. So I'm trying to work on how do we retain physicians. We cannot get a child psychiatrist in our state. That's part of the challenge. We're trying to put laws to it to try to attract them. And we have a huge agenda in the Public Health Committee and the Children's Committee. We are putting a lot of bills this year to try and address some of these issues. But these are systemic issues that need fixing, like yesterday. And we have to have multiple fights to be able to get to that point. And thankfully, I'm hopeful we'll move in the right direction this session. And in some of those aspects, except the malpractice insurance, and that's something we'll have to fight. The argument is that we are an insurance capital of the world. So every time they say, "Oh, we are the insurance capital of the world," I say, "Well, does this give them a green light to abuse us?" Because that's what they're doing right now to all citizens, and that's not a signal. Now we actually are the we have the headquarters for the tobacco industry in Stamford as well. So when they came over to this Connecticut to make the headquarters, I said, well, now they're going to be untouchable too, because you don't let us touch the insurance companies because they live in Connecticut. So just sharing my frustrations with all that's going on, but we'll try to fix and bring the laws forward for sure.
Absolutely. Thanks so much for sharing. A great question, Monica. That's like, I know these things take time, like the health disparities, like racism, inequalities. A lot of it's a marathon. And I know we live in kind of that, I forgot who said it, but someone's like, oh, there's this constant mode of productivity. But at what point are we going to take a step back and really be there for the people? So thank you, everyone, for all your comments. Go ahead, Judge.
I know we need to move on. And I just want to say, to Monica's point about women and childbirth and that kind of thing, I kind of want to go to the area of like the mistrust of people of color with clinicians and doctors, and they're not feel like they're being heard. When a woman says, I'm dilating and I don't know what to do, and I'm on my way to the hospital, and she's going to have the child in a taxi cab, and and maybe I'm misphrasing this, but a lot of that goes back to patients of color not feeling like I'm being heard. If she says she's in pain and that baby is going to be breech, then she's in pain. But they're not feeling like they're being heard, and when when there's SIDS involved and these kind of barriers, and just like Dr. Altere said, I'm not a woman, I would never have a baby, so I really can't speak on it. But women, I really would like to hear, your experiences with, that was going to be part of the topic tonight, but the lady wasn't able to come on, is addressing women of color with, in health disparities. And I think people like Henrietta Lacks and, people that gave themselves and they felt like feeling like they were experimented on, has a mind play in people today, not only in the past history, but in people of color today, where they're thinking, well, a prime example with the COVID shot. A lot of people of color didn't want to get that because they felt the government was experimenting on them. Until, so I just wanted to address that.
Absolutely. And I see, Monica, you have your hand up first. Go ahead.
Yeah, so just to kind of touch on that. So one of the things that we see in our committee, right, is so we actually started to implement a question about bias and discrimination in the review of our cases, because what we're finding is that when it comes to labor and delivery and prenatal care, I feel like often women as just a subgroup as women don't feel heard. From my own personal experience, I had several issues as being a white, educated, middle-class woman, but who was overweight. And so when I was beginning to show preeclamptic symptoms, for example, gaining 11 pounds in 1 week, I was told to go take a walk and eat less. Not, oh, your blood pressure has been steadily rising and your calves are retaining so much water that you can't walk, and then had to be, induced early and everything else. That's amplified in communities of color, especially when you look at the history of obstetrics and slave women being the guinea pigs for different procedures and basically, excuse the pun, birthing the practice of obstetrics and gynecology on plantations. That's ingrained, I think, in a lot of women who come to get care. So, I think it's, it was revolutionary to see a Black baby in a medical book just recently. Like, that was not something that has ever been seen before. And so I think there are strides being made by a lot of women who are making noise in this arena, but there's definitely leaps and bounds that need to continue to be made.
Absolutely. Thanks so much for sharing. Go ahead.
I can quickly respond to a couple of things. I completely agree with what you're saying. And I just wanted to add, there's data to show that male doctors for all of the women's specific procedures, do not necessarily give the same amount of pain medicines that a female doctor would provide. So what you're saying is shown by data, and it also shows that the minority women do not get the same amount of pain medicine. So we will have a bill this session to try and address that as well. The other part I wanted to mention is that the outcomes also show that the minority OBGYN doctors and minority pediatricians show the outcomes for the newborns are better when you have that. So that's also panning out as well. And the bill that we passed last session was the SB1, which talked about racism being a crisis in our state, the public health crisis. That actually was one of the arguments that we were also using to explain that this is part of the problem, that the outcomes are directly linked, and we have to actually identify ways of addressing that. And clearly, there's an area of opportunity. Thank you for that question and comment.
Absolutely. Thanks, everyone, so far. Any other comments or questions before we get to our final 2 questions? Oh, awesome. This is a great conversation. So I know that this is a part of the conversation on race, but this is a part of how we can hopefully inspire each other to take more action to help change some of these inequalities. And speaking of change and action, it gets to our next question of what can health professionals do to take action against health disparities, whether you're in the community or whether you are supporting them, and how can the community, so everyone here, because we're all stakeholders here, how can we in the community support healthcare professionals? So how can we better support you? So I know there's 2 parts. So I'm going to put this in the chat. So what can we do to help you all healthcare professionals? And then what are you all seeing as well? Go ahead, Liz. Oh, you're muted. Can't hear you. Ooh.
In my profession, we have to have bilingual speech language pathologists, and there is a growing number of them, but we also need to be learning a second language when possible, but we not counting on that as being very reliable. If we do crappy Spanish, we have to do better than that, or whatever the language is, but we have to support the education and inclusion in our programs of students of color and from a wide variety of other countries, because you can't assess a child and say that the child has something wrong if the tests are biased and based upon white data, or if the language is not understandable. And bilingual speech pathology is just absolutely crucial. And then if at the least have an interpreter available to help people so that they can be understood in the exam. And finding interpreters, I know, is difficult and at times impossible, but we have to strive harder to be sure that we understand the people that we're seeing.
Absolutely. Thanks so much for sharing, Liz.
So as health professionals, I think the first thing we have to do is recognize and acknowledge that health disparities exist, because some people really think it's not real, or some people think that racism is not a public health crisis. And so we do have to acknowledge it and admit it and work together to fix it. And I feel like part of my job is not only to take care of my patients when they're in my office, but to also advocate for them all of the time. And so part of what healthcare professionals can do is share the stories that they see with people like Senator Anwar and Representative Garibay, who can make policy changes and really try and help to fix the system, so that we can close the gap with the inequalities in health and access to health care. So that's some things that we can do as professionals.
Absolutely. Thanks so much for sharing. Dr. Alerte or Dr. Anwar, whoever wants to go first for this next one.
I have a longer answer, so I can go after Dr. Alerte.
All right.
And I'm actually going to steal Dr. Terranova's answers. So that's not even, I'm not even playing fair anymore. I we in the medical community need to own our own racism. And the first thing we need to kind of do is not feel like we are morally bankrupt because we are racist. There is no other outcome when you grow up in society, right? That is pretty much structured, and the real world is the real world, right? If I stir my coffee with a fork, you'd be like, that's wrong. That's not the way it goes. If my wife didn't take my name, there would be raised eyebrows in my family about why did you take your name? Because there are cultural expectations. I call racism, it's pollen. Racism is pollen. We all know it's there, right? It's a harbinger of spring. It's awesome. And a lot of us don't care about it because it doesn't really affect us. Some of us see it as a minor nuisance, like, oh, it's on my car and my car's green now, right? Some of us welcome it, like, oh, look, the flowers will come. And some of us are crippled by it, can't walk out the house, choking, eyes red, sneezing. But we all know it's there, right? And we all accept its existence as the natural order of things. But some people are really hurt by it, but we're all covered in it. And getting people to understand that will help Black faculty get promoted. And they don't at the rate that their white colleagues do. It will help changing the cases so it's not just white skin. Scarlet fever doesn't look scarlet on a Black person. I will never blush if I'm embarrassed. I'll turn burnt umber. Like, it's not gonna happen with my skin tone. We need to educate each other better, own our own biases because we all have them, and then be ready to kind of fight the bias, right? And the biggest bias that we have, especially working in Hartford, I've seen, is the bias and the blatant racism of low expectations. I've never seen someone walk into my clinic in Hartford going, my God, I can't wait to see who's going to be the next doctor coming out of this clinic, right? Like, we don't walk into Hartford schools and saying, there's going to be like 9 lawyers in this class, 6 doctors and 2 rocket scientists. The person who finds a cure from AIDS is born in Hartford right now. We don't think in those terms. We have these assumptions that it's going to be a bad outcome, and then we're done. We need to switch that script really, really fast. And I think that's what we can do as physicians.
Absolutely. Thank you so much for your response, Dr. Alerte. And then before Senator Anwar shares, Lisa, do you have a follow-up you wanted to share real quick?
No, I'll let Senator Anwar speak, and then I just had a quick comment. Thank you.
Yeah, no problem. Just want to make sure everyone's heard. Go ahead, Dr. Anwar.
Thank you. I just wanted to acknowledge the fact that I'm learning both from Dr. Terranova and Dr. Alerte, and I'm taking notes. Thank you so much for your insights, and I'm truly getting blessed from your knowledge. In the intensive care unit, when I'm with a patient or in the office at times, and I have a student or a resident with me, I say to them that diagnosis for bed 12 is this and this and this. And I say to them that you would call that a diagnosis, but I would call this a symptom. The fact this patient is in the ICU is the symptom of what's wrong in our society. And then you go into the society to fix the disease because the symptom is what we are seeing. So that's the transition from a bedside clinician, a policymaker. And my part of my journey is related to the frustration that if I can do this right, I will be without the medical job because nobody will be in the ICU. Why? Because we are not fixing the things early. And as a policymaker, if we can take care of the people in the community, we would be able to have no patients in the intensive care units or in the doctor's offices because we are failing on the policy end. And that's why I'm in the policy arena trying to address some of those things. And I also wanted to mention a few things because the systemic racism, there's a perfect storm that's going on from the policies that the government has made, but they have now been joined the industry. And I'll share some examples with you because it's worthy to explain that, because we are moving in a direction where we will not have enough healthcare workers and physicians to be able to manage what's in the pipeline with the industry joining in. I'll give an example, and it's a painful example, but it's a very real one, and I'll explain to you what's at stake. In 2020 alone, $84 million were spent by the sugary drinks industry to market only in Spanish language for the children to take on the sugar drinks. And that's a tenfold increase that was there before. I was having a conversation with a hepatologist out of Yale a few months ago, and they're saying that they're seeing epidemic levels of liver disease in Hispanic. And the fastest growing reason for liver transplants right now is liver disease associated with the sugary drinks, with what we call non-alcoholic steatohepatitis, NASH. NASH is a precursor for cirrhosis, is a precursor for liver cancers, which is associated with the high content of sugar that is being sent to our children like there's no tomorrow. And going after minority children, more so African American, but far more so the Latino community in our state, in our country. And if you look at that, 45% of all Hispanics have some level of NASH right now. That's almost close to half the population. And it has doubled in the last decade in the children. The diabetes rates are doubling, and the companies are making profits like there's no tomorrow. And they're shameless about it. That's one example. I'll give you the second example. Of the tobacco industry, 39% of combustible market is menthol cigarettes, and 85% of all African Americans are actually consuming menthol cigarettes. And 2 years ago, I put in a bill that was killed because we make $300 million from taxes from the menthol cigarettes in our state. So we make money from the lives of our citizens. And actually, I asked that question in public. I said, well, you're killing this bill because of the money. So tell me, what is the dollar value for an African-American adult or a child? So I can stand where you start, so I can have an argument so that we can look at the medical cost of that and try to counter it. But the menthol cigarettes, the tobacco industry had the nerve to fight me and other legislators to say that we were racist because we wanted to limit or ban menthol cigarettes. Believe it or not, that's how crazy they are, that they're saying, well, because African Americans are using it, you want to ban it. Well, so, well, you're the ones who've been marketing it with multiple study after study after study, that the marketing is multifold higher within the minority communities in the African American, and you're actually giving free samples in some of the places, and you have resulted in a population that is now addicted to it, and they're dying from lung cancers, and I'm seeing them, and then you're now saying that it's racist policy to try and ban the menthol cigarettes. So the system is benefiting from the companies, and the tax is benefiting the state. And we also, as a state, have not used the tobacco settlement money to be able to address the tobacco cessation. The dollar amount in 2021 budget for tobacco cessation from the tobacco money was $0 from our state of Connecticut. I put in a bill, killed. Now, actually, I've got another bill, since I'm now the acting chair of public health. I've got a bill again to actually put $12 million for tobacco cessation. The vaping industry is no different. So I have these professors who are attacking me because I want to ban the flavored vapes. Everybody knows that the flavored vapes are bad. Everybody knows that the children are getting addicted. And they're saying it's good for you, and it's okay because people are not going to pick up the combustible cigarettes, so let them have the vapes. This is the argument. So the companies that are making profits from the organized racism is very real, and they are at times in sync with some of the policy in the historical policies. And going forward, we'll have to fight those aspects, but it's a perfect storm that's brewing. Now mix that all up along with the lack of access, and along with that, the lack of appropriate training, and we are on the brink of a disaster which is increasing rather than decreasing. So we will have to intervene, and we will have to maybe not be polite anymore about some of these things, at least in our conversations. Because it's very easy for all people in power to try to kill some of these bills, but there's a rationale for this. There's a reason for it. There's a depth for where we are coming from. And that's why elections do matter, and education do matter, and conversations like this do matter. Sorry for a long answer, but this is where the fight is. And the corporations have so much more money that it's almost impossible to fight some of them as well. Thank you for allowing me to speak for longer. Thank you.
No, absolutely. Thanks so much for sharing that, Dr. Anwar. It's just such a deep issue, and but thank you so much. That was an excellent response. I know, Lisa, you want to share?
Yes, well, I just have to say, Dr. Anwar, yes. I am in complete agreement with everything you're saying, and you've summarized everything that we've spoken about so beautifully. But the point that I wanted to make prior to that was also to thank you for your work on the racism as a public health crisis. But I would be remiss if I did not mention to the people here that in attendance is Counselor Nushet Black-Burke, who is my fellow counselor, who was actually instrumental in bringing that to the Windsor Council. And we at Windsor, and I have to say it, Dr. Anwar, were the first town in Connecticut to pass a proclamation of racism as a public health crisis. So I do have to thank Councilor Black-Burke for that. And then I also wanted to say, I answer the question, how can you support healthcare professionals? And I think I've heard from healthcare professionals, but also know from my political background as a deputy mayor, and also being a part of CEA, Connecticut Education Association, retired, that we need to show up at these hearings and we need to pass these bills. That a lot of times, we as very interested and active citizens come to these workshops, which are fantastic, and these need to continue, but there is political action that needs to take place. And that political action starts with just people like us showing up at a legislative hearing, or submitting testimony at a legislative hearing, or even increasing the communication from the health professionals to the community or to the groups that we belong to, such as Connecticut Education Association Retired, or the town council, or whatever. So I would just say, for anyone listening that's here, thank you for being here, but also remember that political activism, writing letters, speaking out, sharing what you know, talking to friends is a way to support our health professionals in their efforts to be more equitable. Thank you.
Excellent. Thank you so much, Lisa. Again, it's very multifaceted in how we can support one another. And speaking of support, we're getting into our final question before I turn it back over to Judge Washington. But what types of trainings are held to address social inequality within the healthcare system, or lack thereof, depending on, I know you all are coming from different kind of studies or practices. And I'll put this question in the chat for everyone to read a bit. What types of trainings are held to address some of these issues? Go ahead, Dr. Alerte.
Oh, yeah, okay, very cool. So this is my bailiwick. A significant amount, and it's been growing steadily year by year. We have continually and historically had students come in and work with practice patients to practice their skills. So these are, actors who not only portray a medical condition, but can also evaluate the students, not only on did you ask the right questions, but did you ask it in the right way? Did you hit me with a ton of jargon, or did you explain to me, what was going on in terms that I could understand? We've been expanding our education in terms of bias training, in terms of, internalized bias, doing a test called the IAT, which pretty much measures your internal bias towards some things, or what are your preferences. We've been doing microaggression training. So knowing what to do with the backhanded compliment, right? Oh, you speak so well. I'm like, well, of course I do. Thank you. But right. And how to handle microaggressions as well as macroaggressions in terms of advocating for your patients as well as your peers. We've been always a part of the community. And we will always have clinics in places like the Bergdorf, like CHS, where we have students rotating in places of the greatest need, but also of the greatest diversity. So we've been trying really, really hard. I run a course, I'm going to be running a course on the power and privilege of medicine, really looking at race from internalized race to dealing with microaggressions to little a advocacy to big A advocacy, like how to get to know your senator and talk about these things next week. So we've been working really hard, at least for UConn. And I think every other medical school has been working very hard. I will speak for Yale, even though my shade of blue is a different blue than Yale's, but they have done, a good job, especially in pediatrics, trying to recruit a diverse class of physicians who will be training in Yale. There are a ton of little things right now. It's like all silos. I think everyone said we need to do something, and we all kind of started doing it, but they all kind of do it at their own kitchen tables. And now it's a question of getting everyone who's kind of like working in med in their particular space, be it the residency, be it administration, be it at the university level, to kind of all work together is the big next step. So the answer is a lot. I hope that helps.
No, absolutely. Thanks so much. Go ahead, Dr. Terranova.
Yeah, so, and I would echo everything Dr. Alerte just said and say that we're also doing that at the faculty level, because I think the students in the younger generation are often miles ahead in this area than some of us older folks who are faculty and didn't have implicit bias training or microaggression training when we went through medical school. And so really trying to get the faculty to be on the same level field of understanding what these terms mean, how to be not just an advocate for people, but an upstander when you see a situation where there is a microaggression occurring, to be able to address it and call it out and educate somebody. And so a lot of that training has been going on over the past years as well, so that it's really trying to change the culture within the system, so that people don't just let these things slide. If I see something happen to Dr. Alerte, I need to speak up and say something to really protect him and protect my friend and protect my colleague, and let the other person, the offender, know that that's not appropriate and not acceptable, and not to embarrass them or call them out in front of him, but even to just pull them aside and let them know what they did. Because as we know, these things happen unconsciously, right? That's part of that implicit bias, that we don't really recognize how we're thinking or how we're acting. And so we're really trying to make sure that at all levels of the healthcare profession, people understand and people react, and really people try and change what the culture is.
Absolutely. Thanks so much for sharing. Go ahead, Dr. Anwar.
Thank you. This is a very good question, and I would say this question is should be a work in progress for all of us. I actually tried to use some vignettes, and those vignettes are about the social determinants, and have these real cases that I actually present to the students, and these are illnesses that are associated with the environment, where a person from the day they're born, all the cards are stacked up against them, and they have severe asthma. They are been on steroids most of their childhood, and they are unable to get a job right now because they're short of breath, they're obese, they still live in the same home that they were in, and then you walk them through how appropriate interventions have been able to change the trajectory of their life. Because they were treated differently. There are new medicines that are available. They were weaned off the steroids, taken out of that environment, and then started to show evidence. So I've got vignettes that actually experience about the social determinants of their respiratory illness, and then what can be done to intervene and help them out. In the inpatient setting, another challenge along with this is there's a lot of opioid and alcohol related patients who come in, and there is again a bias around that too, because it's honestly, when somebody's detoxing, they're not nice to the nursing staff or anybody else. And so what I have tried to do is, thankfully, I have patients who have been able to overcome some of those addictions. And when they have, I try to have a conversation and bring them to the ICU, and then have a conversation with the nursing staff, because once somebody's able to overcome their substance use challenges, they're amazing people and they give back to the community. And then when you have that story, and then they see the person and how some things have changed in their life, and their work was not in vain. All the challenges they were experiencing, that actually puts a little bit more value in why we do what we do, because we see more failures than we do successes, and at least in the ICU setting, because they're back in the ICU, it's a revolving door. And so that's something that we look at. And I also, I had a patient who appeared mentally disabled, but was perfectly fine, but in her appearance. And I would actually have that patient interact with my students and residents in my absence. And I would get a full report how they were treated, because this person was as sharp as anybody could be, but in appearance, she would not look that. And then she would say, well, such and such student, this, and this, and then I would actually know, and then I would actually be able to help them recognize that. But I wouldn't tell them that this is a person who is perfectly smart and able to understand everything, but that person was there. She's no longer there now. But having ways of trying to understand some of the things, I myself am a work in progress on this. I think that the more we try to, with humility, understand the depth where somebody's coming from nuance of their experiences, we cannot get better. So I have a lot of more work to do myself, and then hopefully with that, I can be better in educating others. Thank you for that question.
Absolutely. And thank you all for such great answers. Because again, like, that's why we have these conversations, because things don't stay the same over time. Like, thankfully things change over time, so that way we can better support one another. So thank you to all our panelists and everyone for coming tonight. I'm going to turn it over to Judge for some announcements and closing thoughts.
I just want to thank all of our providers that were able to join us tonight, Dr. Terranova, Dr. Alerte, Dr. Anwar. I am so grateful for you all being here and expressing your concerns and opinions on this topic. I know the audience is so happy to have you as well. And I thank you for being here. Just some quick announcements in closing. Next Sunday, due to the things that are going on in Ukraine, we will be having a peace vigil at Grace Church. Father Chip Elliott was so gracious in allowing us to have a vigil in his church. And I'd like to thank Marsha Hinckley for being a part of that. Thank you so much. But with everything going on in Ukraine and all the craziness in the world, we just think that we have to respond as a community. So I hope you all are able to be a part. Look for the email will be sent out soon with my ugly picture on there. And then invite people that you know, and to help us to send a message to Ukraine that Windsor supports you in this fight. And I'm going to invite old South Windsor on over too. So, so maybe Dr. Saeed and Ritu can come over and bring your community. Also, don't forget, we have Windsor Bridge Builders Award on the 10th, which is next week. We have two awesome people that are bridge builders, and Dr. Terranova and Dr. Anwar, who are on. I'm so grateful that they are bridge builders. But we're adding a new one. We have three actually. Councilor Nugent Black Burke is also a bridge builder, so there are three. But we're gonna add little Miss Lisa Bress over there to the mix and see what she does. So I'm so grateful that we are adding you, Lisa, because I think it's well deserved. We will begin celebrating Women's History Month. So look for that news, and we're going to highlight some women in our community that step out and do the work. So look for that. And then on the 20th of March, we will have a discussion just like this one on anti-Semitic. One of the panelists will be Councilor Lisa Bress. And we will have members from the Jewish community to talk about anti-Semitic behavior, which is another crisis. So we got all kinds of crises going on here. So it is definitely a tornado. And I hope that you will join us, spread the word to your friends of these conversations. The conversations are available on YouTube and the Town of Windsor website. So I thank you for being a part. Thank you, doctors, so much. And I look forward to seeing you again real soon. Take care.